Triana gave the first presentation. Um, but well, I don't know if you're going to raise your hand or if you can unmute yourselves and say, yes, you were here or no. I just want to see if I have to do the introduction again. But hearing no answer, I will
No,
go ahead and do the introduction again.
you're
Thank you so
the
much,
first
Dr.
one.
Oh,
Frey.
you're welcome. Thank you for being here. So this is our second Jaminar in the series of three on Alzheimer's and other such diseases. A Jaminar for us is a webinar or seminar that's targeting the Jamaican audience. So hence we say Jaminar. JDTAN, JDHTF. JDTAN is the Jamaica Diaspora Taskforce Action Network, and JDHTF is the Health Task Force under JDTAN. And both organizations or both entities exist to leverage knowledge and expertise in the diaspora for the benefit of our brothers and sisters back home. We have partnered with the Center for Cognitive Neuroscience and Aging at the University of Miami to bring you tonight's presentation, which is the second in a series of three Jaminars under the umbrella topic of the Healthy Brain Initiative. Specifically, tonight's topic of discussion is understanding mild cognitive impairment, or MCI, Alzheimer's disease, and related dementias. Dr. Triana Abel Encarnacion is our presenter for this evening. She is the outreach coordinator at the Center for Cognitive Neuroscience and Aging at the University of Miami. With over 7 years experience in community education, she is passionate about educating others on topics such as nutrition, exercise, and brain health. Her main goal is to make clinical, medical, and scientific information clear and simple, thereby contributing to the health of our community. So please help me give a rousing welcome to Dr. Triana.
Thank you so much again, Dr. Frey. Thank you.
You're welcome.
So today's topic is our second presentation on the series of Healthy Brain Initiative. And of course, I'm going to start first saying that I'm here with two of my co-workers, Doctors Crenshaw and Dr. Ortega, and they are there in the background. So they probably will say a few things at the end, maybe, and it's wonderful to have them here today as well. They are neuropsychologists at the Center for Cognitive Neuroscience and Aging, and we are pleased to be here today bringing the topics. And now the other thing I want to say is I'm going to start talking about what we mentioned in the last presentation, because although it was recently, it's been 2 weeks, correct? So I will just go over to what we saw. And if you remember, we were talking about normal aging. We were establishing the differences of what we consider normal when we age and what is not that normal or what is not expected. Then we talk about the trajectories of age-related cognitive changes. We talk about the umbrella term of dementia. We talk about the prevalence of most of the most common dementias. We talk about risk factors, pharmacological treatment options, non-pharmacological treatment options. Also, we spoke about the common misconceptions about medications and what we should know about the supplements that are commonly around. And also, we spoke about the importance of research. So today, I want to mention a few of the things we mentioned before, but going a little bit more in depth. And also, I'm going to present this new topic. So today we will be talking a little bit more about mild cognitive impairment and specifically about Alzheimer's disease. Also, I'm going to mention the treatment options that we currently have that are FDA approved and what they do, because I know I mentioned a few examples of the mechanisms, but there is always a good way to explain things or a better way to explain things. And we can make it simple. And the more we repeat these important informations in the community, the better. Because sometimes we can get the information, but once when it's about healthy brain, it's not enough. We have to repeat and repeat and repeat these great informations because this is what changes our community health. So also I'm going to mention about nutrition. I'm going to talk about exercise and how this is related to cognitive health, and also a little bit about caregiver challenges, because maybe one of you or maybe one of us have been a caregiver of someone with dementia. And we know, if we have been a caregivers, that being a caregiver to someone with dementia is different. So there are a few challenges that caregiver experience, and some practical tips that somebody here in the audience might need to listen. So we will provide that information. And also remember that always at the end, we have the space for the questions and answers. So if I don't think I'm not like the best checking the chat while I'm presenting. So if there is a comment, please write it, or please feel free to write it so I can go over it while I'm presenting between one topic and the other. So that way we can continue the track of the information, and I can also like go back to the question or repeat myself if needed, okay? So let's begin. So we will begin today with mild cognitive impairment. And as we mentioned last week, this is characterized by noticeable changes in cognitive functions, such as memory, thinking, language, and judgment. But these changes are different than having dementia. And also, these changes are different as having a normal cognition. It's like something that is in the middle. So the person has changes in the memory, thinking, language, judgment, but they are not on a point where these changes interfere with the day by day, with the daily activities. So this person, these people stay cognitively functional in certain ways. And this is what distinguishes the MCI, or the mild cognitive impairment, from dementia. And here we have a chart, because I know we spoke the last presentation a lot about some MCIs that are reversible, but I stressed a few times that not all the causes of MCI are reversible. So if someone is in the point of having an MCI, that doesn't mean that just because they have a diagnosis of MCI, it's reversible. So we have to know what's the cause. And if the cause is reversible, once the cause is fixed or once the cause is treated, so this person can go back to being cognitively normal and continue aging as a cognitively normal individual. But if this person has an MCI, or a mild cognitive impairment caused by a condition that is not reversible, for example, here I have Alzheimer's disease that can be an underlying cause, or any other dementia, such as Lewy body, such as frontotemporal, vascular dementia, or Parkinson's disease dementia, and others. So this means that even if we do our best, it will be progressing until it becomes dementia. And also there are other causes that are non-progressive, such as traumatic brain injury, sleep apnea, and like a singular stroke, where even though when they happen, they might keep the person in the same level, but still with mild cognitive impairment, like not on their normal line, but in the MCI level. It's different than progressing until they come completely, when they lose completely their activities of daily living, or the activities that help them to have like a normal day by day. So I'm gonna show again the same graph that I love with the lines that I was trying to do with my hands. So I'm gonna explain what I said again with this graph. So as I was saying, there are some causes of MCI that can be reversible. For example, we can say some people that have severe depression, or if they have like a vitamin deficiency that can alter their brain function, or another cause, for example, anxiety, severe anxiety, side effects of some medications, infections, and multiple medical conditions that have that person in chronic stress. This can be a cause of MCI that once the conditions are stable, can help the person to go back to their normal condition or stay there on the MCI line. So going back to the graph, so some causes of MCI, they are progressive causes. So this means that this line can keep progressing and progressing until it comes dementia. And the difference from MCI and dementia is when the person is not able to do their day by day, when their cognitive function is declines more and more, and this person needs more help. For example, if they forgot to some appointments, there's a point where this person doesn't even know that they had an appointment. Or other example is when they drove to their usual places, like familiar places, like going to their house every day. These people can get completely lost and not being able to know or to remember the route to go back home, where this was something that was usual. And here we have some of the aspects of MCI, of the key characteristics of it. So the memory loss, this is often the most prominent symptom, especially in the type of MCI that is called amnestic, where people primarily experience memory difficulties. But there are other types of mild cognitive impairment that not necessarily are based on memory or are non-amnestic as we know it. Also, besides memory, people can notice changes in other aspects, such as planning, following instructions, making decisions. And despite all this cognitive change, they preserve their independence. So they can do their day-by-day activities. The MCI won't impair them in such a point where they are not able to do their own things, right? And they can require assistance. So it's very important to know the difference between MCI and between dementia. And I would say that the main difference is the independence of the individual. And then, as I said, individuals with MCI have an increased risk of developing Alzheimer's disease or other type of dementia, but not everybody with MCI progresses to dementia, because it depends on the etiology of the MCI. And also some people, when the cause is reversible, can even go back to normal cognition if the cause is something that we can reverse, or it's something that can be stabilized. And here I have some myths and facts of MCI, because I think this is a way to retain more information when you know, okay, this might be a myth. Let me remember. So what's the fact? This is something that helps me to retain information, and I always love putting myths and facts in all my presentations for this reason. So I have here 4 myths about MCI. And one is that if you suffer from MCI, you will develop dementia in the future. Those who are diagnosed with MCI do have problems with memory. However, it depends on the etiology. It depends, and people are at risk, but that doesn't mean that it's warranted that they will have dementia. So the most important thing here is that if you ever get a diagnosis of MCI, it's crucial. It's very important that you are followed by a neuropsychologist, by your psychiatrist, by your neurologist longitudinally. So at least every year, you are seen by someone expert in cognition or someone that can see you and see the progression. And that way, you know where you are at, if you are progressing, if you are not progressing, the causes of that MCI, and obtain a better picture of your condition. The second myth is that there is a specific factor which causes MCI. And the fact is that researchers do not fully understand what causes MCI. So it's impossible to target it or to give it to one risk factor or to a single risk factor that causes the development of MCI. And some of these risk factors can be like biomarkers, like the ApoE4 gene, and also like atrophy in the brain, that when we see the imaging, lifestyle factors like certain cardiovascular habits or certain nutrition habits, smoking, and many, many, many things, cardiovascular health in general. But these are risks, and it's like a combination of them. We cannot only attribute it to one specific thing. And the third myth here is that if you suffer from memory loss, you probably have MCI or mild Alzheimer's. Let's remember that part of normal aging can be forgetting a few things, but slight things in where we can go back to our normal. For example, okay, I can forget appointments from here and there, but it's not something that happens every day. Or it's not something, or okay, I forgot what I was doing, but it was because I was multitasking, not because I was distracted, thinking about a problem or thinking about something I have to do that has me under stress. This is different than forgetting just because I'm forgetting everything. So once you have abnormalities regarding cognition, it's important to make an appointment with your physician. And as I said before, I cannot stress this enough. It's not only going once, but if you receive a diagnosis or if you still have concerns about your cognition, it's important to always go. And if you're not happy with the first thing that someone told you or a provider told you, seek a second opinion. It's valid to seek a second opinion too, but it's always good if you have a concern to get answers for that concern. And the fourth myth here is that there's only one type of MCI. And as I mentioned in the other slide, we have amnestic that entails memory, but also we have non-amnestic that is not necessarily about memory, but other cognition domains, and also can affect only one domain or multiple domains in the brain. So it depends. So the amnestic MCI affects only the memory, but there are a lot of types of it. So it's important to know because you can have MCI and have your memory intact. Okay, so now let's jump into the Alzheimer's disease. And because we spoke about the umbrella last time and brought up all the prevalence, and we talked that, we said that the Alzheimer's disease, it's the most common neurodegenerative disease of the brain and the most common dementia. And it affects from 60 to 80, it entails from 60 to 80% of the dementias. It's very important to know the key or the basics of Alzheimer's. So here we have the normal brain on letter A, and we have a part of the brain that is showing the cortex, it's showing a part that is called hippocampus, and then we have a neuron, which is the main cell in the brain. So when people have Alzheimer's disease, what happens in the brain is that the brain starts to shrink. Some areas that are supposed to be small become a little bit bigger because of the shrinkage of the brain, right? And also some areas that are crucial for our brain function and our thought processing start to shrink too. So in the neuron, in the cell, we can see that these changes start microscopically. So here should be inverse. This picture should be inverse or reversed. But here we can see that there are two proteins that accumulate in the brain, basically. So these are the tau, which are, they accumulate inside the neuron. And then the other one, which is outside, which is the beta amyloid, they accumulate outside. So what happens is that the neurons, they are connected. So the electricity goes in the neurons in and out, in and out. With this accumulation of proteins, that function of the brain, it's impaired. So the nutrients cannot flow good on the brain. And these two proteins are found normally in the body, but the problem is when they accumulate in excess on the brain. So this is basically what happens. So all this damage that happens in the cells happens then in the cortex of the brain and then affecting the entire brain, affecting all the normal functions as we know them. So I'm going to show, and I hope the explanation was as simple as I could. I hope you like the explanation. I'm going to show some symptoms again. So some of the symptoms we have seen, some of the symptoms that are common in Alzheimer's are poor judgment, difficulty with memory, difficulty with completing familiar tasks, difficulty with planning, with executive function, confusion with time and location, like difficulties with orientation, also problems with calculations, difficulty with words, trouble with images and spaces, recognizing people they used to know, unfound emotions, and withdrawal from social activities. And also misplacing items, hiding items, and then don't knowing where they were or where they put them. And if we could classify the Alzheimer's in 4 stages, we could say that the main or the basis would be cognitive impairment. We could say, okay, stage 1 could be MCI. So in the first stage, we can see that people have forgetfulness and misplaced items, slowed speech, gait impairment, poor coordination, depression, lack of personal care, collecting, hoarding, agitation, mood swings. But I always, when I mention about these stages, it's always good to say that people are different. Some people can experience a few symptoms. Some people can only have one symptom. Some people can have all the symptoms. So all people are different. And also when talking about the progression, when you look online information about Alzheimer's, they say things along the lines of, oh, Alzheimer's starts 10 years before showing symptoms or 20 years before showing symptoms. And then you read another text that says, oh, Alzheimer's progression between stages is 2 years, it's 6 years or more. It depends. Because this, every person is different. Every patient can show a disease in a different.
Dr. Tanner, 1 second. I think someone's speaking. Could everyone please mute yourselves? Thank you.
Thank you so much. Thank you so much, Dr. Frey. So as I was saying, every patient is different. So the progression of a disease will depend of many factors, but also how the patient is treated is crucial to see how long the patient is going to last in one stage between one and the other, or even the risk factors, genetics. There are so many factors that have to do with it that makes this disease a complex disease as well. But we have to think about when we read online that the years and the timing we see are not necessarily what's going to happen with your patient or with your loved one. So if we go to the early stages, we can see that in the memory impairments, they can repeat themselves too often. They can be unable to read or to write, to do calculations. Also, they can have problems substituting words or saying incomplete sentences. They can have some clumsiness, falls, poor coordination, movements in the hands or movements along the body. And then they can have wandering. They can go wandering outside or having delusions, paranoia, confusion, episodes of confusion where out of the blue, they don't know where they are, even if it's a familiar place. Also, the anxiety, the agitation, and the mood swings are part of these early stages. And then in the middle stages, we have inability to dress, and also resistance to help from others when they are going to be dressed, and no name recognition, loss of spatial awareness. It can be hard to comprehend what they say. Also, visual impairment. It's very hard for them to see like as before. And then severely decreased motor skills, like the movement can be impaired as well. And then the wandering, anxiety, hallucinations, paranoia, and sleep apnea. And also apathy and aggression. And in the late stages, people can lose completely their short-term memory. So they can be unable to have new memory or to form new memories. And then people say that's how people say like commonly, like, oh, they go back to their past, because that's where the memories they keep are the ones that are from the long term. So when they see pictures of family members that are right, the present pictures, they don't recognize their kids. They don't recognize granddaughters or grandkids, because they still have the long-term memory, the memory from the distant past, but the memory from the present is no longer there. So it's hard for them to know, and they get confused. Who is that person who is calling me mom? Because I don't look like I'm your mom, or things like that. Also, the speech is different. It's like gibberish. They have incontinence, Parkinsonism, difficulties eating, swallowing, drinking, and still the wandering happens, and the aggression and mood swings happens too. So I'm gonna talk a little bit later about this, but this part of the middle and late stages of Alzheimer's disease are like, although the condition itself it's hard for caregivers, the late stages are the hardest, because this is when most caregivers feel the burden. And the fact that they are not able to be with their loved ones, most of them say, oh, I feel that my loved one is not there anymore. Where is my mom, or where is my dad? They are not there anymore. It's the body, it's the person, but when I try to communicate, it's not possible to have the person that was there before. And this is often very hard. So now I'm going to talk about the journey of a patient that has cognitive complaints or any cognitive questions and wants to go to a physician. Because it's important to know what to do if I am the one that has a cognitive complaint. Where should I go? So if you experience memory problems and thinking problems, it's important to get a cognitive assessment. And it's part of, for example, if you have Medicare, part of the annual wellness visit. So the person has to discuss these problems with the PCP, who is going to conduct a physical exam, who has to order a few tests, blood work, imaging to see how things are, and ask about the medical history and family history, because this is important as well for the profile of the patient. And then if the test suggests MCI, so this provider is going to refer you to a few, or can be to one of these specialists, can be to a psychiatrist, can be to a geriatric or a neurologist, depending on who is more accessible. For example, here in Florida, we have a few memory disorders clinic, which are centers that are state funded, that are basically the centers for excellence to treat people with Alzheimer's. And then when you go to a memory disorders clinic, you can receive further evaluation. So it's going to be, I could say, very different to what the PCP is going to go. So some people go and then the PCP refers them to a memory disorder center or memory disorders clinic or to a psychiatrist or neurologist. But others that already know about the existence of the clinics, they just make the appointment themselves and they go. So if the evaluations they receive confirm the MCI, that person is going to get diagnostic biomarker testing and brain imaging. But oftentimes you get all those indications or orders right when you go to the memory disorder center or when you go for the first time to your neurologist or geriatrician. And then if the tests show beta amyloid accumulation, the person returns to the specialist and treatment options are discussed. And if treatment is started, the person has regular visits to the place they are referred to, and they get regular monitoring and evaluation of the treatments. And this is good to know because we have to understand what happens after you feel that you have a cognitive complaint. So now I'm going to be talking about the treatments, and I'm going to be mentioning what we mentioned last time. Oh, Marcia has a question.
Yes.
Yes?
Yes. Hello, Dr. Triana. I know I asked this the last time, so I'm going to, I have two questions, but I let the first one go until later. Regarding the Alzheimer's, what is, from your professional experience and judgment, who is the typical
Who is the
patient that you
typical?
see? I know you
I'm
work in a
sorry.
research institution, so the University of Miami is.
I'm sorry, Marcia. I lost you a few seconds when
You
you
did.
asked
Okay.
who?
Who
When you
is
started
the
the question.
typical, yeah, who is the typical patient that, well, you see? I know it's a research institution, but with,
Yes.
okay, what I'm trying to figure out in my mind how, in, let's say, a regular clinic, a regular community health center, for example, would you find the type of care that you're suggesting here? You mentioned earlier under MCI longitudinal care. Okay, and I think that's great. But who is a typical patient in that type of setting? In, let's say, the FQHCs, federally qualified health centers, community health centers.
For example, at the center, although we do research, we have the memory disorders, the state-funded memory disorders clinics. So we don't see a lot of the patients from research in the clinic. Like most of the patients that go to the clinic go because they are referred by their PCPs. So an ideal patient is someone that, for example, has a PCP that knows about our clinics all the state, and they just refer them because they have cognitive complaints. Sometimes they go without even a diagnosis. They go, okay, memory loss. That's all it says.
Okay.
And most of them, when they go to the clinic, most of them, no, now it's like 100% of them. We changed the way we were seeing them before, the new patients. So now everybody that goes for the first time to the clinic has to get the order of the blood-based biomarkers, gets the order for imaging. Oh, yes, primary care physician, it's PCP, yes. and also gets all the blood work to see how is a complete blood count, how is everything. So it gives us a picture. Also, the person for the first, every time they go for the first time, they get a neuropsychological evaluation. They get a few tests that take like 20 to 30 minutes to see how is their cognition. And then this happens one day one. Then in 3 months, when they are seen again, they go with the results and they get the whole diagnosis if it's possible. But this is not oftentimes what you can do, because it depends on how the person is. There are some cases where you cannot get a full diagnosis on the first visit because it will depend. If the person has, for example, comes to you for the first time with an MCI, and you know it's an MCI and you know the cause, and you were able to treat the cause in 3 months, 6 months, you are able to see if there was an improvement in their cognition, or if it was stabilized. Whereas if the person comes with moderate dementia and we couldn't get the reason why it was, which dementia they have, it is a little bit more complex, because we have to dig deeper and see how they react with certain medications, how they evolve, or if the medication works well. So it's complex, but most of the patients come because of the PCP, and others because they heard that another person went to the memory disorders clinic and they wanted to know. And others come from a neurologist or come from a referral from another psychiatrist as well, because the main doctor that leads the center at UM, she's a geriatric psychiatrist.
Okay. I guess my large question is there a culture of, and I know I posed this question last week as well, 2 weeks ago, is there a culture of memory care within our larger healthcare system? That's what I'm trying to figure out.
Yes.
How would we overlay what you're all the beautiful work that's being done
Yes.
onto the regular healthcare landscape, like we do with certain other things? Have a mammogram every year, and all of these things that everyone knows that they should do as part of normal health. How do we overlay this on the larger healthcare landscape, and especially in those communities where they're underserved, populations are underserved?
Yeah.
How do we overlay this? I know it's probably outside of the scope of what we're talking about here, but it is, I think, really important to think
yes,
about.
and I remember that we were talking about how important is to educate the community, but also include the doctors or the physicians, the primary care providers that serve the community, because most of them can be doing this for 4 years, but they might not know that we have blood-based biomarkers. They might not know that there are research, state-funded places, state-funded clinics that they can refer their patients that are covered by insurance. Or they don't know that some fairs are happening that they do memory screening. So as simple as someone going to a memory screening in a community health fair gives them something to go there then to another provider. So I think it's a lot of work in the community that needs to be done, that we are doing it, but it's still, like, I think all the centers that have memory care, they should be out everywhere. Like, you should be able to go to any community and see a flyer of brain health, or see a flyer of why your memory matters. Because I know we are focused on cardiovascular, and that is the similar answer that I said that last time. We are focused on cardiovascular health. We are focused on brain health, or diabetes, the other chronic conditions. But when it comes to memory is not a priority, and it should be.
Absolutely.
And it takes, I know sometimes for the matter of a visit should be 15 minutes or 20 minutes, but it should be everywhere. And when people look at the portals of their centers that they go, there should be something about memory or a flyer, something as simple as a flyer when you're waiting on a doctor's appointment should be there, because you see it for cardiovascular, you see it for diabetes. Why not for memory?
Let's change that soon. Okay, thank you, doctor.
Yeah, we are trying our best, and I think it's gonna keep growing and growing and growing, and it's something we will see in the following years.
Wonderful answer, Dr. Abel. And just to add to that, there's also a conversation that can start after that. Because from a cultural perspective, I mean, I can only speak about, me growing up in a Latino household. There's a lot of misconceptions about what normal aging and like what is a decline that is significant versus not. And even the thought of, of going to a psychiatrist might be scary for some people because they have like these misconceptions as to why as like you might be needing to see a psychiatrist. So yes, unfortunately, we are trying every day to change that by bringing education to communities, religious centers, YMCAs, to have these talks and to bring awareness to people because yes, culture does impact how we seek help and who do we seek help from in the communities. So this is what we're trying to, as part of the ORE core, which is the outreach and recruitment, this is what we're trying to do, not to recruit, not to bring people to the studies, but mostly to inform.
Inform, yes.
Yes.
I agree with that point of view because culture imbues everything that we do, whether it be in health, in our enjoyment, everything. So I think we have to reach the people first because it's gonna take a while for the doctors to start ordering, say, a memory test as a routine. But if we educate the public, I think they will start asking for these things. Just like with any new medication, they hear it on TV, they go into the doctor's office and say, okay, I want Ozempic, I want this, I want that. So I think we have to empower the people through education, and then they will change the healthcare system.
Yeah, I mean, look at the situation we have made. Speaking of Ozempic, we have made weight loss. I mean, that's not its primary, right? Its primary, what do you call it, use right now. Well, maybe it is switching right now, but we have made that acceptable, even sexy. I believe that this is such an important topic. We are all going to age if we're lucky enough to be alive. We're all going to age, and many of us will age very well. My grandmother was 99 when she died, and she had her full faculties. My maternal grandmother was 86, and she was diagnosed with Alzheimer's. She had all the symptoms that you discussed from early to late stages. She had a good personality, so the aggression was not part of the litany of symptoms, manifestations, but the memory, the long-term memory, the short-term memory, the hoarding, the day-night thing, all of these things. And I would like to see memory care because we're all affected by it. I'd love to see this be a normal course of care, like as we discussed, cardiovascular, diabetes, weight loss, sexual health. These are things that are recently become acceptable as part of what human health is. This should be something that is out there for first and foremost. I believe that this is something that we're all going to struggle with, either personally as we age, or from our family members, or friendship circle, or colleagues. And it is, I believe, something that I know in my own country, in Jamaica, I wonder how we would even integrate this into that type of healthcare system. I know we within the United States, in the underserved populations where I do a lot of my work as an epidemiologist, that's not something that's important. Look, if you can feed yourself, you're lucky, and obviously you have to deal with your cardiovascular things. The memory care, well, we'll see how that goes. I know I'm taking up a lot of time here, and I appreciate the feedback, but I do think that this is something that we're probably going to be talking about, or we should talk about, for a very long time to come.
Thank you so much, Marsha.
Thank you.
So going back to the treatments, as I mentioned in the last slide, then when the person has or gets it's diagnosed with MCI or with early stages or Alzheimer's, it's time to get treatments, right? After diagnosis. So in the last presentation, we had the differentiation between the two groups of treatments, of pharmacological treatments. So we had some drugs that are symptom improving drugs, which are the donepezil, rivastigmine, galantamine, and memantine. And these mainly work by increasing the neurotransmitters in the brain to help brain function. But one, the memantine, this protects the brain from excessive levels of glutamate, which is one of the transmitters that is different than the others that we want to like keep high. This glutamate affects the neurons and it, I would say, damages the neurons and then they die. So we want to prevent that. That's why we provide memantine. And this, as everything, has side effects, such as headaches and nausea. And then we have other treatments, which are the newest ones. And these are the latest FDA approved. These are the disease-modifying drugs. And these are intravenous. These are given with a strict supervision because these target the disease underlying biology. And if we go back to the first slide about Alzheimer's, where we had the neuron, and I was saying that the protein that accumulates starts to kill the neurons. So these intravenous infusions, which are the aducanumab and the lecanemab, these two attack the plaques, specifically the beta amyloid plaques. So these slow the cognitive decline and the functional decline in early stages of Alzheimer's. So it's only FDA approved for early stages of Alzheimer's. This is not for all dementias. This is not for moderate to late stages. This is reserved for early stages of Alzheimer's disease. And this is very important because the side effects that these intravenous drugs have include infusion reactions, include amyloid plaque-related imaging abnormalities, can have brain hemorrhage or brain hemorrhages, and then bleeding, swelling, and these can be, can help to slow the cognitive decline, but they are still on their clinical trials. So these drugs, although they have been approved, they are still on trials. So if people are in early stages of Alzheimer's and they are eligible, some doctors recommend them to go to trials if they want and see how it goes. But they are still on trials. So here I have the same drugs I mentioned, and I'm just going to say, yes?
What's the cost of the new drugs?
Well, it's very expensive. It should be over 10,000 monthly. And right now, I know there is, I don't remember where exactly they have the trial, but they have a trial in Miami that they are doing with lecanemab. And they are accepting patients. So I can forward that information to you, Dr. Frey, because I have it on my email. But they are actively recruiting people for those trials all the time. And it should be over $10,000 a month for sure for the intravenous monoclonal antibodies. So I'm going to mention the name and the brand name because in the US, we know the names, we know the drugs, but sometimes it's the brand that sounds more catchy. So it's good for educational purposes to know when you hear that name, it's related to a memory medication or an Alzheimer's medication. So here we have donepezil, galantamine, and the rivastigmine. Donepezil is called Aricept, galantamine is Rasadine, and rivastigmine is Exelon. And these three are, they are cholinesterase inhibitors, so they prolong the acetylcholine in the brain or in the neurons. And then what they do is that they prolong that neurotransmitter. So they help to have more of that transmitter and continue the brain function. But we have common adverse events. We have nausea, vomiting, diarrhea, loss of appetite, muscle weakness, weight loss. And from all these medications, I know they all come in tabs, but the only one that comes as a patch as well is the rivastigmine. So for patients that are in mild to moderate dementia, they come in patch. So you just put the patch on the skin and change it every week or so. And it helps for them to be like, to have the medication continuously in the body. And then the memantine, that is one of the ones you want to hear the most, is Namenda. This is an NMDA antagonist, so it basically blocks the glutamate or the excess of glutamate and causes dizziness, headache, constipation, and confusion in the patient. So here we have how is the infusion or the disease-modifying treatment and how it works. So we have the Leqembi, which is the lecanemab. The anti-amyloid infusion, it's injected to the patient. So it travels in the body, it travels basically to the brain. So these antibodies attack the plaque, the protein, the amyloid protein, okay? And then, so this reaction attacks before it forms the plaques. And this is the way that it can improve the cognition of the patient and the function. But as I said, there are a few side effects that also are important to take into consideration. And then now, of course, there are risk factors that we always have to take into consideration. And these risk factors are very important. Not enough exercise, smoking, hypertension, diabetes, depression, excessive alcohol use, obesity, and hearing loss are important risk factors that we have to take into consideration to be able to stay healthy and to preserve our brain function. And then I want to talk a little bit about nutrition, because nutrition and exercise are crucial and are the two things that we can do, the best things we can do for our overall well-being. So in terms of nutrition, we hear a lot of diets. We hear a lot of things that are miracle for the well-being. But the most important thing is that following a balanced diet, following a diet focused on eating green vegetables, eating colorful food, and not processed food is crucial. It's vital to maintain the brain health. Some nutrients that are very important are the omega-3, fatty acids, all the antioxidants, such as the ones that are in the colorful vegetables and fruits, such as here have peppers, we have like greens, and we have onions. The more color the fruits and vegetables have, the better. And there can improve your brain function and slow cognitive decline. Also, consuming probiotics found in fermented foods like yogurt, kimchi, can reduce symptoms of anxiety and depression. Eating dark chocolate in a small amount, I have to mention that, right? This contains flavonoids, and these can improve cognition and boost your mood. And also, there are some foods that are not as good for us. For example, a diet high in sugar and in processed food, it's known to be pro-inflammatory. So things that are pro-inflammatory and that can promote your sugar levels to be high in your body, also can, affect your brain health. And they increase the risk of depression by 60%. People tend to either eat too much or too little. So overeating leads to weight gain, and eating too little leads to exhaustion. And also processed foods with additives stimulate the dopamine centers in your brain, which they are addictive, and they are associated with pleasure and reward. But what happens is when you have all these processed food and you're addicted to them, you can't stop. And then you eat and eat and eat them, but there is no way to regulate that reward system because you are addicted to it, and you get all the consequences. Yes, Marcia?
Dr. Triana, do we have any studies that show the difference in dietary consumption and level or the prevalence of Alzheimer's? Do you know of any of
That is
those?
a very good question, and I'm going to forward a good paper I read about that on it was Harvard, I think. Guess what happened with that paper?
Tell me.
There is a diet that is called the MIND diet, which is a mix of the Mediterranean diet with the DASH diet. The DASH is the one that is recommended for people with high blood pressure. So what happened with the control groups of these diets, of the MIND diets, is that it showed that people absolutely can get improvement in their cognition, but they were doing cherry picking on the study.
Okay, so it wasn't published?
Yes. So that was the best I could read, but they were doing cherry picking, which means that the population that were recruited, they had family history of Alzheimer's. They also had higher level of education, but they didn't have a comparison group with people that are part of the general population. So you can say it works, but if you don't have a long enough trial with that diet, you don't know if it works really. And if you don't compare it to the real life, to the real people that are among the communities, it doesn't show if it works well for everybody.
Okay, so there was a bit of a selection bias there. Okay, but I still would love
a lot of selection bias. And this is one of the
paper. Yeah.
And it's a barrier we have in research.
Okay. All right.
But I will forward that to you. So if you can write your email, send it to me in private, I will send it to you.
I'll look. Do you know? Okay, excellent. I appreciate that. Thank you.
You're welcome. Okay, so now I have another graph, and it's basically 5 foods linked to better brain power. As I said earlier, green veggies. So leafy greens such as kale, spinach, collards. These are rich in nutrients like vitamin K, folate, beta carotene. So these plant-based may help slow cognitive decline. Also, the fatty fish and everything that is full of omega-3 fatty acids. This is good to lower the blood levels of beta amyloid. But remember, beta amyloid, it's a protein that is natural in our bodies. So this can lower the level of it. And this can, help, but this is not something that is going to cure. Like, we don't have a cure for Alzheimer's and for this, I would say, disease process or like disease formation, okay? So we also have the berries, and they have flavonoids, and they help to improve memory. We have tea, coffee, the caffeine that helps us. It helps us to have like a lot of brain function when we need it the most, right? So these are good in moderation. And also nuts. Nuts are excellent sources of protein and healthy fats, like walnuts. They can help with brain function. And also exercise. And in exercise, I was trying to look for a picture that showed like brain exercise. I mean, it is a brain exercising, but I was meaning like more along the lines of brain games, brain teasers. I couldn't find that, but I will mention it. So physical exercise, it's great because it protects the brain health. It helps with the delivery of nutrients to the brain. The more you exercise, the more brain blood flow you will have. Also helps you to sleep. If you sleep good, you will have a great life. If your sleep is great. Also, it reduces depression because it releases endorphins. It helps with stress and anxiety. It improves your cognitive function. It boosts confidence, self-esteem, and manages pain. The stronger you are, the better. The stronger your muscles are, the better. And also, another risk that is not here is that the more active you are in your golden years, less likely you will be to have falls. So the fact that you are preventing falls because you are more balanced, because you are more stable and stronger, it's great. Because if you fall, you might have a hip fracture. You might have like a brain injury, right? So if you're strong, you can prevent all of this and you can prolong your life. And also I would say the stimulation, social stimulation, talking to others, interacting, learning something new. Also, like, can be a new language. This can be like doing Sudoku or like a game, an app you just downloaded in your phone. Things that keep your brain in function and things that keep your brain always working. Okay, this is crucial to keep your mind and your brain healthy. And now I'm gonna be talking about the difference when we have to be or when we become caregivers. So when we are caregivers for someone that have, for example, chronic kidney disease, it's very different than we are caregivers of someone with dementia, because there are some conditions that we become caregivers of our loved ones that their cognition stay intact. So we feel that the person is still there. We can talk to them, we can interact with them. Although it's sad that they are sick and they have a chronic illness, we are not seeing them going back or like becoming fragile and not being able to interact with us. So there are a few tips that are important to give to caregivers, because in most cultures, there are some ways, and it's part of being a caregiver as well, part of the denial, when we have to face the disease and also lose our loved one in the process. So it's important to communicate clearly. When speaking to someone with dementia, it's important to use basic words and simple sentences, to be as clear as possible, to be as easygoing as possible with your loved one. Also, to approach them softly. If someone with dementia fails to recognize you, do not be upset. Be gentle with your approach and try not to surprise them, because they can have an episode of confusion. Also, do they understand your questions? Make sure you ask simple questions. Avoid open-ended questions or asking more than one thing at a time. And also avoid trying to push them to say you an answer. And it's something I see often, all the time. When I ask a question to the family, to the patient, sometimes the caregiver is like, you know the answer, say it. And I know it's part of what we understand, they understand, but we have to let them be. And it's hard, but also it's important for them not to be stressed out, not to be frustrated. And they can be easily frustrated by that. Also, don't criticize them. Those with dementia are generally confused, and be patient with them. Like sometimes, for example, some people with dementia, they make comments about strangers. And they can make comments that can be hurtful. But the approach shouldn't be the caregiver saying the patient, hey, don't say that. Do not say that about the person, because most likely they don't even know, or they will forget about that. They will get angry because someone is bossing them around, but the other person won't even hear. Or if they hear, it's better for you to go to the person and say, hey, my mom has a disease, or she's suffering from Alzheimer's. I'm sorry. Than going to your loved one and telling them, oh, this is bad. You shouldn't do this. You are making me feel bad about this. Like, no, it's easier just to go to the other person and just let it be. And I know it's easier to say than to do, but these practical tips really help. And when patients and family members learn these techniques, their way of managing their loved ones changes a lot. So I also have 10 tips to manage stress and to be a healthy caregiver, because I know that part of being a caregiver is that sometimes we forget ourselves. And it's important to take time off. It's important to deal with their own stress, to know what resources are available. Some centers, some associations like Alzheimer's Association have like support groups that you can just go or just find online. A group can be a Facebook group, can be from another social media that contains people that are also caregivers, where you can talk to them. And this is a way to help, or to be helped, to receive help. And also to become an educated caregiver. There are so many resources that you can read online, and also that can help you to know what's best, what to ask to the primary care physician when you go again to the visit, and also what's going to happen next. It's good to educate ourselves constantly. Also to get help, find support. Alzheimer's Association has a helpline. It's below here on the image. And also making financial and legal plans ahead of time is important once you know the diagnosis, to manage your levels of stress, going out, finding techniques that work for you, exercise, cooking, or traveling if you can, or when you can, things that work for you. And taking care of yourself, eating as good as you can. Or if your therapy is getting your nails done every week, do it every week. Try to do it every week to help yourself to be balanced, to do the things you can do for yourself. And also knowing that you are doing your best. Because the fact that you are taking care of your loved one, it's gonna make such a difference in your loved one life, and also in yourself. And accepting the changes as they come, because the needs of a loved one or a patient with Alzheimer's change depending on the progression of the disease. And it's important to be accepting every change and asking the questions you have to the providers to see what's best for every step that is coming. And also not forgetting about yourself, going to your appointments, going to every appointment you can go for yourself, because sometimes what happens with caregivers is that they are taking care of someone with a chronic illness and they become sick, or they had a chronic illness themselves and they got worse because they were not being able to go to their own appointments. So it's also good to take some time for you as much as you can, and to pay attention to your body, because that chronic stress can also make conditions that you might have in the past or you don't even know you have. The chronic stress can make you have new illnesses too, and it's one of the main causes of stress. I mean, of diseases, in chronic illnesses in general.
There's a question in the chat.
Yes, I was gonna answer that one. Yes. Are seeing hallucinations typical symptoms for Alzheimer's? No, it's typical for one type of dementia, or for two types of dementia, actually. So we say dementia as an umbrella term, where Alzheimer's is one of them, the most prevalent, but also we have others. We have Parkinson's disease dementia, we have vascular dementia. So some types of them, such as Lewy body dementia, is characterized by hallucinations as typical symptoms. Also, some types of frontotemporal can cause hallucinations, and depending on where a vascular dementia is more affecting the brain, can cause hallucinations. So you can have people that tell you that they hear people. I mean, patients with Alzheimer's can say, oh, I'm hearing my mom calling me or someone that is deceased. This can happen, but it's not part of the typical symptoms that we see. But depending on where it's affecting in the brain, yes, you can hear the report of them having hallucinations, visual and also auditory hallucinations, such as hearing things and hearing commands from people. Okay, so I will move the presentation to the Q&A part. So I know I answered a few questions throughout the presentation, but this is the time for us to talk about it. And if you have more questions for us or any comments in your experiences, feel free to mention your experiences as well, because I know we covered a lot of topics today. And I love when you guys interact with me. So please feel free to chat, to write on the chat or mute yourself.
Dr. Triana, that was amazing. That was fantastic. Really, really informative.
Thank you, Dr. Frey.
And I realized that, my mom, she passed away 2 years ago. She probably had Alzheimer's of some sort because of the behavior, some of the behaviors that you covered tonight, and but when you're in the situation, even sometimes as a healthcare professional, you don't see it because you're looking at it from an emotional perspective. But
Yes.
now that she's not here anymore and I can look back objectively, I see that she had some of those symptoms. For instance, the hoarding. she and she was always accusing somebody else of taking her stuff. So, um, but I had one question. Would you mind giving us an example of persons who suffer from non-amnestic MCI?
Yes. So
What are some of those behaviors?
yes, so I will go back to the amnestic and non-amnestic. So if people were not here when I was talking about it, they can understand what I mean. So, okay. So with mild cognitive impairment, we can classify it in two. We can say amnestic when it affects the memory, and then non-amnestic when it affects other cognitive domains that are not memory. So we have other domains that are attention, that are executive function, language. We also have visual, spatial abilities. And I think I'm going correct, right? I have my wonderful coworkers here that are neuropsychologists. So they are the experts. So, okay. So when you have no non-amnestic MCIs, is that other domains, for example, attention, is the one that is affected. So this person can have problem shifting attention or like doing activities, or if they have language problems, they can have trouble finding the right word to say or following a conversation or changes in the way they have their language.
I can provide like a really good example.
Yeah.
This is a particular case of a veteran that stayed with me after all these years because he was one of the very first cases that I that I treated, basically, this was a 60-something-year-old veteran who was complaining of having memory difficulties. When we did the full neuropsych evaluation, we saw that his memory was affected, yes, but it was affected because he had a lot of difficulties paying attention. So in true form, his memory was affected due to his low processing speed, so not thinking as fast as he would have want to, and reacting as fast as he would have want to. So yes, in retrospect, the profile was not necessarily amnestic because there were other domains that were affecting his memories. Looking at his chart, we saw that he actually was diagnosed with sleep apnea, and because of difficulties adjusting to the machine and feeling kind of like very like drowsy waking up and feeling very dry mouth, he was not wearing his CPAP machine. So we saw him and we were like, okay, whatever you do, whatever you leave with today in the feedback is you have to wear your CPAP machine. After seeing the results, that was kind of like an awakening for him. And he started wearing it religiously. The change that we observe on this man a year later, simply by using his CPAP machine, which, I mean, I say simply, but in reality, if your lungs are not receiving oxygen, your brain is also not receiving oxygen. So just by doing that change, that was very significant, the profile that we saw 12 months later was completely different. This man ranked in the average to high average range in most of the domains that we saw. And that was an incredible change from scoring in the severely impaired, moderately impaired. So the good news about a lot of the recommendations that we give is that you have the power to make changes in your life. And of course, they're not going to be always easy. It requires discipline. It requires daily checks-ins. But at the end of the day, he was able to see this. And we did like this beautiful chart for him with the results comparing baseline to follow-up. And I always talk about this case because it was like, I don't know, one of my very first cases and ones that is very fulfilling because people listen to the feedback, and it's giving feedback is an art because we can spend 10 minutes with a patient or an hour and nothing sticks. But giving feedback in a way that people understand and it is tailored for them makes a world of a difference.
Thank you so much for that example.
Of course.
I have a quick question. This is Dr. Tracy. I came on a little late, so I don't know if it was discussed. Have you seen have any experience with folic acid helping Alzheimer's? Because my mom was diagnosed with Alzheimer's 20 years ago. She's still alive. She's, progressing. She's declining, slowly. But when she first got diagnosed, there was a study that said that taking folic acid daily will slow the progress as well as caffeine. So I've had her on folic acid all this time as well as she's on Exelon. And she declines, but she'll stay at one stage for like a year or more, and then you see another decline. Have you seen the study or had any experience with this?
No, I don't have no, I don't have experience with folic acid, but on last presentation, I gave the most common vitamin and supplements that in what we know about them. And we need supplements in the body. We need vitamins. We need them all to have a healthy brain function. So the fact that one person can do good with certain supplements and last for longer, it will depend of so many factors that we don't know. So the fact that that helped your mom, it's wonderful, but also there might be other factors that can help her too, like her genetics, how she is, if she's active, her nutrition in general, other things that also will play a role. Is she someone active? Is she someone that eats well?
She eats well. She's not as active anymore because she's more bedridden now, but she eats well, and occasionally She can't hold a conversation, but occasionally she'll just come out and say something that will just shock you. Like this weekend, she just looked at me. She's not had a conversation this weekend. She looked at me and she just said, "You're pretty."
Oh,
and
that's
you know,
amazing.
right? Yeah. And normally she doesn't talk.
Nice. Thank you, Dr. Tracy, for asking that
Mhm.
question.
You.
Mhm.
I saw a hand up, and it disappeared. I don't know who it was.
Yeah, I had a question very quickly. You had mentioned, and your colleague mentioned the uh, amnestic and non-amnestic. How nuanced is the difference, and how can a caregiver take advantage of the difference?
I think at the end of the day, the difference lies in etiology. So, for example, like Dr. Abel was explaining at the beginning, MCI simply means my cognition is not as good as it used to be, and it's a significant change, but I'm still able to keep my daily functioning. That's where MCI is defined as, and it's a gray area because you can either, this is your new normal. You decline a little bit due to aging, perhaps more than your peers, and you're going to stay like this until, the end of your life. That's one option. The other option is like, okay, we identified that you have MCI. We think that it is due to all of these other things that are not progressive, like, for example, untreated depression, anxiety, PTSD, CPAP problems, cardiovascular illnesses that haven't been controlled, even things like uncontrolled HIV are known to cause problems in the brain and therefore problems in cognition. And in this case, we offer this feedback. There's plenty of things that can be done to help ameliorate those difficulties. And then you can see a change, not perhaps to, the person we were when we were 30 or 25, because unfortunately, we're never going to go back to that, but like more or less to your baseline, something that you're comfortable and you see an improvement. And that is fantastic. And then the third option is, unfortunately, if you get diagnosed with a progressive dementia, is that we expect that is going to continue to progress. Sorry for the redundancy. If that's the case, what we can do with that feedback is we can help you remain as functional as feasible for as long as we can to keep you, engaged with your family, engaged in your community. Because unfortunately, at this moment, very sad to say that we don't have a cure for Alzheimer's. So usually when it is a progressive amnestic MCI, it tends to be associated with conditions that are going to continue to get worse, like Parkinson's, multiple sclerosis, Alzheimer's, and cardiovascular as well. On the other hand, things like traumatic brain injury or a stroke, which is also a cardiovascular form of dementia, you get, for example, a stroke, right? And that first year is the most important year of your life because we still have a period in which we can gain some of that function back. This is why speech therapy, PT, physical therapy, occupational therapy, cognitive rehabilitation is extremely important in that first year because we can continue to get better. After that year, unfortunately, I have a lot of patients that come to me like, Dr. Ortega, I had a stroke 7 years ago. I feel like my memory is not gonna is worse. It's not getting better. At that point, it's a hard conversation to have, but it is likely that this is your new baseline because the vast majority of regeneration and neuroplasticity occurs in those first 12 months, and that's why it's imperative that people know this.
Okay, thank you.
Absolutely.
Thank you so much. Are there any other questions? Any other comments? Well, it's 9:30, so we're going to wrap it up. So I'm going to ask Marcia to formally thank Dr. Triana and her team before we sign off.
Well, I have spent a lot of time asking a lot of questions, and I have a million more. Let me do apologize to
Okay, Marcia, we
my
know.
colleagues for that, but I am very thankful, and I'll just say I'm not very good at these things, but I will say that I know that this is a lot of hard work. I know that this is a lot of very dense, very difficult information. Very there's a lot of science behind this, obviously, and we have to make this. You have to make it palatable, pleasant, and easy to digest for a larger audience of people who are also scientists, but also lay audience. So I do thank you for all the work that goes into something like this. It's absolutely beautiful. 2 weeks ago, I had we had such a nice conversation, and I look forward to this conversation again, and I look forward to the other. So I thank you, Dr. Triana. My apologies. Encarnacion is a very difficult word for me to pronounce, so I'll say Abel, Dr. Abel, Dr. Ortega, and whoever else is here as your colleague from the
Dr.
University of
Crenshaw.
Miami.
Yeah.
Dr. Crenshaw, thank you very much. Thank you for the University of Miami for the work that you do. Please put this out in the community. We
Yes.
need this. My colleagues at the JDTAN and JD Health Task Force, thank you for the work that you do. Thank you for having this. And I really do hope that we're going to have this as a continuing series in perpetuity.
Sure.
I know that's a lot of hard work, but I know I appreciate what you're doing. And so I thank you from the team and from myself. And I look forward to the next series.
Thank you so much. So the next one is going to be about, well, basically research. It's research. It's going to be with Dr. Curiel. She is the leader of outreach at the center, and she's a neuropsychologist as well. And hearing her talk about research and why it's important to have diversity in research and what are the community resources we have available for us, it's amazing. So I know it's going to be a wonderful time as well. I'm going to be here too. Probably we will hear as well. But I hope you will have a great time on the third presentation. And this is not the first series that we will have with you guys, okay?
For sure.
Only the beginning.
I appreciate that. Okay,
and before we go, I'd like to thank the Jamaica Teachers Association, the St. Thomas Division. I know we have some of you on, so thank you for joining us. Thank you, Dr. Wright. She's one of our co-chairs of the Health Task Force and was instrumental in getting Dr. Triana and her team to be doing this presentation, this series of presentations for us. So thank you. I know you're not feeling well. I hope you feel better soon. Thank you, Maureen, Dr. Tracy, and my Westwoodites who are here. Thank you, everyone, because without you, we would just be speaking into this Zoom hole. I'd also like to thank our JDTAN technical team, Antoinette Brown and Carlene Tomlinson. Thank you so much. Without you, we could not have done this. So have a good night, everyone, and we'll see you in maybe 2 weeks, but we will send out a flyer with the date and the time and the link for the next presentation.
Thank you so much.
Thank you,
Have a lovely night.
Thank you. You too. Bye-bye, everyone. Good night.
Good night.
There goes Roy Main. I thought you weren't coming.
I've been on.
Yes. Thank you. Have a great night.
You too.
Take care. Bye-bye.